Hello, welcome. Hello. Hello, welcome. Hello, welcome. We are just waiting people entering in the session. Hello. Hello, everybody.
Hello.
Hello, everybody. So I suggest that we start the session and people will continue to join. Good morning, good afternoon, everyone, and good evening for some people we are in the East countries. I am Alexandra Duval. I'm the VP Marketing and Communication for PETERS Surgical, and I'm responsible for education course. Today, PETERS Surgical is pleased to help to facilitate a new webinar from PETERS Academy. PETERS Academy was born this year, considering that PETERS Surgical can help surgical communities to better exchange and learn from each other about local challenge and expertise. Today, we are honored to welcome for the webinar. This webinar is dedicated to a course, an advanced course in coronary revascularization. Today, we are very honored to welcome Professor Verhoye as the moderator, who is the president of the Society from Thoracic and Cardiovascular Surgery in France. And we'll have 4 speakers, Professor Labrousse from France as well, Dr. Tomasi from France, Professor Mishra from India, and Dr. Tomoya Uchimuro from Japan. What we are going to share with you today is the following. Professor Labrousse will present some communication on robotic myocardial revascularization, the state of art. Dr. Tomasi will introduce some hybrid approach on coronary revascularization. Professor Mishra will share with you this expertise regarding the minimal invasive beating heart surgery using Lambert K. Cygnet, And we'll end by the presentation of Dr. Tomoya Uchimuro from Japan on the coronary endarterectomy and ITA long-onlay page grafting for diffusing diseases LAD. Each presentation will be introduced by some short quiz where you can answering about what is your expertise, and you have the presentation and some question and answer. This webinar will be in English for sure. It's a global webinar. You are all in mute. This is absolutely normal. Please ask your question via the question section, and we'll have some dedicated time after each presentation to exchange. This presentation will be registered, so we'll receive the replay just after the webinar. So I will leave the talk now to Professor Verhoye to welcome the scientific part of this session. Thank you.
Thank you very much, Alexandra. So, dear colleagues, dear trainees, everyone, I would like to say you a good morning for some, and a good evening for the other one. It's a real pleasure to meet you in that second session of the PETERS Academy about the coronary surgery. I think it's a very nice field and very smart field for the surgeon, very subtle surgery. And we have to discuss with we have the possibility and a big chance to discuss with 4 eminent surgeons all over the world about that surgery. So we can now, let's go with Professor Labrousse from Bordeaux. Bordeaux is a very nice town of wine, but a very nice town too for surgery in France. And it's a real pleasure to introduce you, Dr. Labrousse, after 2 small quiz. Thank you to answer to the quiz, and let's go now.
We'll ask the attendees to answer to the question.
Okay, the second quiz.
Do you see the result of the first question?
Okay. Nice information. We can go ahead to the next question.
Oh, sorry, I made a mistake. Okay.
About the robotics?
Yeah, sorry, it was my mistake. I didn't send the right one. Could you answer to the question?
Yes.
Could you we relaunch the quiz? I'm not sure that you are able to answer.
It's impossible for us to read the quiz.
Yeah.
We don't have the quiz on the screen. I don't know if, okay.
No,
okay.
Fine. Good job. So just 1 minute to answer. Okay. So now Dr. Labrousse is aware with the answer of the question, and I think his talk will be very interesting for everyone. Please, Dr. Labrousse, and thank you very much to meet you and to join us. Thank you.
Thank you, Professor Verhoye. Dear Chairman, dear colleagues, it's a real pleasure for me to present here my point of view about this very controversial but also very exciting topic, robotic coronary revascularization. So I have no financial disclosure, but I have to say that I am a robotic user and I really trust into the technology. To begin, a few definitions. If you come from on-pump full sternotomy, during the last 30 years, we have implemented our practice with port access approach, with peripheric cannulation and endoballoon for cardioplegia, off-pump multiple anastomosis, and mini-invasive cabbage through mini thoracotomy with concomitant mammary artery harvesting through the thoracotomy. And 15 years ago, with the third generation of Da Vinci robot, robotic coronary revascularization became achievable and multiple approaches were proposed from the simple robotic enhanced midcap, which is a robotic mammary harvesting and minimally invasive hand-sew anastomosis, to the more challenging arrested heart and beating heart cabbages. And during this topic, I will focus on these two approaches, arrested heart decap and beating heart decap. The first technical and key technical point is this instrument, which was developed for the Da Vinci and which is mandatory because it allowed you to stabilize the epicardial surface, but also it induced an irrigation of surgical field. And I said that in the past because this instrument is not available up to now, and unfortunately probably for the future, with a new generation of Da Vinci X or XI. And so arrested and beating hearts robotic should be stopped just due to the lack of dedicated instruments. So here a view of a surgical approach. You have 3 ports along the anterior axillary line for the camera and the right and left hand. And you have here a subcostal port for the stabilizer. Here a surgical view of what happened when the robot is fixed on the different port. And here is a short video of mammary harvesting. So we use usually a hook, as you see here, to liberate the mammary. You have to understand that what you see on the screen is the full visualization you have on the patient, and that the magnification per 10 gives you an excellent view and allow you to harvest without any problem the mammary artery. Once the mammary artery has been harvested, you have 2 options, or arrested heart or beating heart anastomosis. Here is a video from Johannes Bonatti on the case on an arrested heart. And for that, he used extracorporeal circulation by femoral cannulation and undo balloon for the cardioplegia. And you can observe that once the cardioplegia has been done, the surgical field is as usual when you perform it through a sternotomy with extracorporeal circulation. The surgical field is dry and it allows an anastomosis without any difficulties. You see that the control of a needle is perfect and similar to what you have during your usual practice. And you see how nice is the magnification of a view of a coronary artery. And this is especially a perfect approach when the quality of a coronary artery is not perfect, with some calcification, because you are allowed to deal with them as you perform on an open chest surgery. So the second movie from my center is a beating heart TCAP. This technique uses a temporary occlusion of a coronary artery with a elastic suture, as you see here. Then it allows you to open without huge bleeding the coronary artery, which is dissected with a small scalpel. And we use shunt, as we used to use in by sternotomy during mid-cap, and liberate the elastic for the for the coronary flow. And then on a similar manner, the anastomosis is performed with a PTFE suture CV8, and you see that the result is pretty nice too. So for totally endoscopic cabbage, we are facing 2 options, both with their advantages, but also specific risk. First, the main caution that you have to clearly hear is that both techniques were published and developed by very, very specialized and very high level team, and that both procedures are associated with a long learning curve, need optimal intraoperative management of the hemodynamic and of the hemostasis, and require from the surgical team multiple skills. So arrested heart is associated with an easiness of the anastomosis, sure that the reproducibility and variability of anastomosis is better, but it also allows you to deal with all complex coronary arteries. But you need a femoral cannulation, you need to deal with the endoballoon expertise, and it's a huge technology for, I will say, just one or two grafts. On the other side, for beating heart, it's really easier in terms of ECC and management, and you have no cardiac arrest, but the complexity of the anastomosis process is really tough, and it explains that in our experience, but also in other team experience, the learning curve was over 40 to 50 cases, and in my opinion, preclude for the development of that technique. So now a few results from the literature. First of all, if you look to mammary harvesting, it's basically the easier part of the procedure and the one with a shorter learning curve around the 50 cases. It's really, this can be developed everywhere. This figure from a recent review from Bonatti team shows that during the last 5 years, we observe a very nice decrease of the conversion rate of this procedure, probably due to the better selection of patients, but also improvement of all the surgical steps. A similar improvement of the procedure was also previously published regarding ECC time and cross-crop time, but you see that for that, the learning curve is close to 100 patients. If you focus on beating heart tick-up, the first point is that multiversal revascularization is achievable, and in this recent review, about 45% of patients receive 2 or more grafts. The intraoperative results were not so bad because on more than 1,000 patients, you see that the conversion rate was close to 10%, but you have to note that the procedure time was over 4 hours. However, early postoperative results are excellent, with a mortality rate close to 1%, stroke rate below 0.5%, and length of stay in a hospital really decreased dramatically compared to open chest surgery with a mean below 4 days. And this key point is really in terms of economical assessment of a technique regarding a classical open chest. Finally, midterm results of this technique on a beating heart totally endoscopic CABG is also excellent, with a freedom from MACE, which include graft patency over 85% at 6 to 12 months. Similar results were observed during the arrested heart TCAP. Multiversal revascularization is also possible and usually performed. The mortality on this huge review of more than 1,000 patients, conversion rate is 13%, and you see that cross-crop and CPP time is not too long, but when you add CPP to robotic harvesting and all what you have to perform during the procedure, you observe that the operative time is now over 5 years, which also, in my opinion, preclude for a large development of such a technology, and is also a sign of a huge complexity of a process. When you look to early post-op results, you see that perioperative mortality is very low, 0.6% in this huge cumulative series. Stroke rate is a little bit higher compared to beating heart and is likely related to the retrograde flow of CPP. And you see that the length of stay in that case is 2 times longer compared to the beating heart and similar to what you can obtain with open chest surgery. Finally, midterm results are also excellent, but with a freedom from MACE reduced compared to beating heart TCAP. But, and this slide is a key slide, and I think is the award of all these surgical difficulties. Patients' recovery is 2 to 3 times reduced compared to the classical open chest surgery. This is, in my experience, also the main advantage of these techniques. It's a huge improvement for our patient and explain that over all the drawbacks of this procedure, I really still trust in this therapy, especially in center with an easy access to the robot. Finally, you understood that the main drawback was the anastomosis time. Maybe this TAPR will be the future, but even if preliminary results were excellent, their price and the low rate of use of these new devices, in my opinion, also preclude for a real development of this technology. And I really don't think that this new anastomosis device will become a game changer in our practice. So to conclude, we must probably forget the dream of totally endoscopic coronary bypass, but not the robotic approach. I really trust there is a place for robotic mammary harvesting combined with angio-anastomosis through a real small mini thoracotomy without any rib retraction. It increases the length of the mammary, it increases the quality and the diameter of the mammary, and all of that simplifies the anastomosis. Moreover, in some cases, it allows if you need to add the extracorporeal circulation, and this is especially true for multiple revascularization. And through the mini thoracotomy, you are able to obtain the quality that you used to have with angio-anastomosis. So my real conclusion is that although clinical results were promising in expert team, arrested heart and beating heart TCAB are prone to disappear due to the lack of coronary stabilizer and due also to the complexity of the procedure. Robotic Lima and Reema Harvesting and mini thoracotomy and angio-anastomosis is less technically challenging, as it's probably the best of the two worlds, classical open chest and robotic approach. However, this last technique also needs a specific training and requires specific tips and tricks. So consequently, only team with high volume should try to develop such a program in order to be able to achieve similar clinical results to those obtained in classical open chest surgery. And that's why this is my view of this new world. Thank you.
Thank you so much, Louis. Thank you so much, Dr. Labrousse. It's a real pleasure to have the news of innovation in coronary surgery. So we can share now that presentation with the audience. And I think we have a question from Japan. And the question is about the cardioplegia. I know that in your presentation, you precise some things about the cardioplegia. Do you develop? The question is, how is cardioplegic solution injected?
In our experience, we used to use a crystalloid similar to Del Niro cardioplegia in order not to have to re-inject cardioplegia. The fact is that with the endo balloon, it's very easy to check and follow the first dose of cardioplegia with TE, and it's mandatory. But as soon as you have moved a little bit the heart, all reinfusion of a cardioplegia is very, very complex to observe on TE, and that's why we prefer using one dose for an ischemic time, which is allowed over 2 hours. So one dose of Del Niro or custodial solution.
Okay, nice answer. Is the panelist have some question for you? Dr. Mishra, Dr. Tomasi?
Thanks. May I ask a question to Professor Labrousse? You know, a lot of development had happened early 20s, you know, the last century in the field of robotic cardiac surgery, and more so on the myocardial revascularization. Why now there is slow growth in the robotic surgery in the Europe and America at this time?
Well, thank you, Professor Mishra, for your question. If I understand your question, is maybe why the acceptance and the development of robotic has been stopped. Basically, I think first the price, but also the results were not optimal. Not optimal because coronary anastomosis is really complex to be performed on a beating heart. And as I explained, if you want to have an easy anastomosis, you have to do an arrested heart. You need to be able, especially on the patient side, to have a true surgeon who has experience with the endoballoon. And it's so many technologies. You have so many learning curves that it's almost impossible to reach the top of the learning curve for all of this technology. Unfortunately, I think the concept was good, as I said, but I think too long learning curve, and during the same time, we have huge improvement of our cardiologists and with new drug delivery stents. So that was not, I think, the good strategy for fighting against stenting.
Right. And we also think that in the industry level, there is no investment. And if you see the XI system, there is no coronary stabilizer. So basically, the new machines are meant for their specialties, general surgery, GYN, not for cardiac. So that may also be a reason. You have SI has a stabilizer, but I have XI system where there is no endo stabilizer. That's again limitation.
Yes, you are right. You are right. Thank you for your comment.
Dr. Labrousse, we have two other questions. How do you vent the left ventricle in arrest heart?
Well, we don't use vent for a coronary procedure during open chest, so we don't use vent also during robotic approach. And basically, it is also impossible to vent through the endoballoon. So our practice was not to use vent, and we have never seen any problem.
Thank you. Two other questions from Japan. How do you decide to anastomosis in robot on the hand?
So can you repeat, please?
The robot or directly with the surgery, classic surgery. When you have harvested the mammary, how do you decide to use robot to finalize the anastomosis with the robot, or to do it like a video?
Basically, with a robot, one of the most complex time is being able to find the target vessel. Even on the LED, it's sometimes very complex because your approach is from the left side, and you need to be sure that it's not very diagonal. So if target vessel, if you are sure that it's the LED, and if you are able to correctly stabilize it with a stabilizer, then you can run for robotic anastomosis. If you have an intramyocardial or even below the fat coronary artery, if the coronary artery is too much calcified, then we used to switch to or mid-cap or to a full sternotomy. But clearly, robotic anastomosis is a very real technical challenge.
Okay. Probably the last question, because we have a lot of questions, and you will have time to try to answer in your email to the question. So the last question, Louis, is how much time is the learning curve for young surgeons for doing robotic cabbage safely? What will be steps of learning and assessment of each step? And I complete the question with my last question. How do you have to go to the robot every each week? how many hours you have in your hospital to perform robots for your department?
Okay, basically, the learning curve for the full procedure is around 50 patients. So it's clearly a huge learning curve. And in my experience, during all this learning curve, we ask proctors, physicians from outside to come and help us. That was the only way to avoid any injury of the heart, avoid a post-op complication, because if you have some complication, you will stop the program. So first thing is that you need some proctoring during long time. It's very expensive. And this is also one of the question about such a program. And I have to say that I forget the end of your question about training. I think we have a simulator of our robot in my department. We have a dedicated robot for cardiac, so we use it not exclusively, but now for mid-cab and largely for mitral and tricuspid repair. But I will say that you need 30 to 40 hours of simulator before being able to work on human. And that's the training plan we organize for all our resident and fellow.
Thank you so much, Professor Labrousse, for that very, very smart presentation. I think it is opening some new future for the young surgeon, for the young trainees, and the new dedicated artistic surgery. And it's very important to have this kind of proposal right now. We are going and moving to the next presentation now, if you're okay, with Dr. Tomasi. Is coming from my team, and we are in the west part of France, in Brittany, is the part of the cider and not for the champagne, but we are also a surgeon and a smart surgeon too. So will expose you now the possibility of hybrid surgery, and I think just after robotics, for the left part of the heart, probably hybrid have a place to discuss today. Please, Dr. Tomasi. We have just 2 quizzes before, and after we are going ahead with the presentation.
So first of all, I want to, yes, we wait for the results. Yes. Most more, but most of us, all of us, true thought that improvement will be mandatory, especially for the future of coronary revascularization. And yes, this is a very few patients in most of our centers. So. Oui, juste partager ici. Partager. So I want to thank the whole team of PETERS for that very interesting topic in coronary revascularization. And I want to thank also my chairman and mentor, Professor Verhoye, for asking me to present that topic. So as an introduction, this is something very, the following of the part of that kind of coronary revascularization with the target to minimize the risk. We all know that PCI and cabbage are 2 very valuable options for treating coronary artery disease, especially in the stable case. The hybrid idea is to capitalize both advantages of this technique while minimizing the limits. So we all know that the left internal mammary artery to LAD is a primary goal, and this is probably the best way to treat LAD. Minimally invasive coronary surgery do have several approaches without CPB and any aortic manipulation. And the idea of hybrid is also one of the points is that saphenous venous grafts are still the most commonly used second vessel for non-LAD target vessels, despite the improvement of bilateral internal mammary artery or even the new recommendation for using the radial artery. The drug-eluting stents are something very valuable too, with the diminishing rates of restenosis, and target vessel revascularization has been improved. So the main idea is summarized in that slide. We all know that cabbage can draw us to the solution of Lima to LAD, but the 30-day major adverse cerebral and cardiovascular events are increased between PCIs. The length of stay is also greater, but the long-term results are excellent. Multi-vessel PCIs, you do have early outcomes that are very good, but the long-term outcomes can be criticized. That's why the hybrid coronary revascularization, with the idea to get the best solution for LAD and secondary solution for the other vessels can be something very interesting. Here an example in which the LAD is severely occluded by atheroma, and we do have a free vessel disease. And in that kind of case, we can perform the Lima to LAD and then perform the stenting of the obtuse marginal and even the right coronary artery. PCI does not perform as well as cabbage, especially in complex multivessel disease. A lot of papers, especially from Syntax in 2009 and all the follow-up, and even in the Excel study that can be criticized for other reasons. We do have a lot of papers that are totally clear about that point. Cabbage in complex multivessel, especially free vessel disease and in the high syntax score, is the best solution, even if that solution can lead to an early morbidity. The primary goal is to protect the LAD that will represent just by itself about 50% of the muscular part of the myocardium. The primary goal is to protect the LAD using the left internal mammary artery. And we can see that nowadays the hybrid approaches can totally be used using the other techniques of minimally invasive coronary surgery, such as robotic assisted cabbage, as presented by Professor Labrousse, totally endoscopic, even in a case of mid-cab. So we can associate a lot of new techniques like that in order to improve the results, especially for the critically ill patients. Mid-cab can lead to something very interesting, but we don't have the thoracoscopic assistance. We need dedicated retractors and even dedicated stabilizers for the anastomosis. The robotic has truly been presented by Professor Labrousse, and TCAB can be suggested as more advanced. Kitara has performed a review with 57 patients. The mortality rate was nil, and the 3-year survival was absolutely excellent with above 93%. But the procedure were very long, with a mean procedure time of 318 minutes. That's quite long, of course, for our cabbage. Here, the example of the retractors that can be used with a dedicated retractor to harvest the mammary artery and then dedicated tools to perform the anastomosis of the LAD. Then when we are using that kind of strategy of hybrid revascularization, the timing between surgery, CABG, and PCI is quite difficult to manage. If we want to perform it as a one stage, it can present some logistical difficulties. The antithrombotic regimens can be difficult to manage with the higher risk of bleeding, especially after dual antiplatelet therapy. And of course, to use an hybrid room is not something that is so widespread nowadays. When we compare HCR, hybrid coronary revascularization, to CABG, Reema has performed a study that must be ended prematurely due to higher chest tube output and need for thoracocentesis. Most of papers are presenting a staged approach that allows teams to maintain antithrombotic regimens, and in that kind of situation, especially in stable CAD, we can perform first the CABG to the LAD, and secondly, we can perform the PCI, and the risk of interim ischemia was quite low, of under 1% in that case. So we can see there which are the main point for one-step HCR or two-step HCR. The main point for two-step that is the most widespread is that the prior Lima to LAD can be assessed, and it can protect, of course, the myocardium from ischemia during the PCI because of the patency of the CABG. In case of one step, the hybrid room is absolutely mandatory, but the short hospital stay and probably the better satisfaction of the patient can be something that we can discuss. In case of acute coronary syndrome, this is a wide, very large field for PCI. So of course, the culprit lesion that is responsible for the acute coronary syndrome will be treated by PCI, and then we can perform the left internal mammary artery to LAD. So the main point is when to interrupt the dual antiplatelet therapy with the risk of thrombosis of the previous drug elutic stent that has been implanted. In the stable situation, the main point nowadays is to perform first the CABG and then the PCI, but the selection of patients seems to be absolutely crucial, and probably this is a very, very small field of coronary revascularization. So we can see that there is an improvement of the way that we can treat such patient. It's not only PCI or CABG. In case of free vessel disease, we can discuss CABG or HCR. Is that something that is anatomically complex? Sorry, so maybe CABG could be better. So I think that that kind of flow chart are now a great part of the heart team, and we need to discuss with the large arsenal of possibilities that we do have to treat those patients. Here some very important papers for that subject. The main meta-analysis that has been performed, because we do have actually very few studies with a small series, and this is very difficult to discuss about any comparison actually. We can just say that the 30-day mortality is good when we compare CABG, when we compare HCR to CABG, when we compare HCR to PCI, we do have very interesting results. The rate of major adverse cardiac and cerebrovascular events are in the field that we already know for coronary revascularization. Which are the true outcomes? So as I just told, much of the data are from HCR versus OPCAB in small series. The meta-analysis show trends that there is lower transfusion, lower intensive care unit, and lower length of stay. But the meta-analysis from Reynolds has showed that there is no difference in atrial fibrillation, no difference in renal failure, no difference in mortality. There is a lack of data, and some of them can be opposed to the other. Because Esteves has described an increased rate of major adverse cardiac and cerebrovascular events at 2 years in HCR procedure compared to cabbage. The long-term results, there is very few patients that has been truly explored for long-term follow-up. The main papers can show us that there is no difference according to the standard of care, especially no difference in mortality, myocardial infarction, repeat revascularization, stroke, and overall MACE. On that paper from Bassman, we can see the long-term results for about 10 years with 100 patients in each group. The mortality was quite low, and the P for comparison show no difference between the three groups. The comparison between HCR versus PCI alone, that must be something very interesting actually, is fairly limited. We do have papers from Puskas that compare 200 HCR to 98 PCI with similar rates of mass at 1 year. But the KEF PCI registry that has been presented there shows something that is quite interesting, because if we compare the hybrid revascularization group to the PCI group, there is improvement that is very clear in high syntax score, and there is a tendency even for low and medium syntax score. So this is something that can be interesting for free vessel disease, even in low and medium syntax score. So, but there is very lack of data. One randomized control trial has been initiated in 2017, but suspended because of challenges with enrollment, and that study has just been stopped. And there is no current study, according to my knowledge. Which are the advantages that we can wait for? The advantages should be the faster recovery compared with traditional cabbage, but it is not suitable for emergent situation, of course. We hope to reduce MACE, especially in the early outcome compared to traditional cabbage, but we want to improve the long-term outcome for PCI alone. That's the main point, I think. So as a conclusion, the overall results are favorable despite of conflicting results, as I just shown you. There is lack of robust analysis, but even with this lack of robust analysis, the current guidelines shown us that there is a place for that kind of strategy. So we can ask and wonder, there is very few patients of the main value of the hybrid revascularization is underestimated. Thanks for your attention.
Okay, thank you very much, Dr. Tomasi. The title of that discussion was not simple. Of course, why discuss hybrid when you are a surgeon able to do a complete surgery? But we know that we have some cases that we have to discuss. And I think the argue of Dr. Tomasi was complete enough in order to start the discussion. So if the panelists have some question directly.
So, Professor Verhoye, I would like to ask Dr. Tomasi that now in this era where we have progressed in minimally invasive coronary artery surgery, which I'm going to, in the next presentation, which I'm going to show our experience, is there is a real role of a hybrid if we talk of. We have mastered to do triple basal bypass through small thoracotomy. We started now bilateral mammaries to dissect through the thoracotomy. And of course, if you are utilizing robotic technology, we easily dissect two mammaries and do a Reema crossover. And then, of course, we all know that arterial grafts are much, much better than any stents. So what is, your take in this modern era where we are advanced technically and technologically? Thanks.
Thanks a lot for your answer, Professor Mishra. I think there is a lot of possible answers because we do have what we can do and what the patients want us to do. And nowadays, most of patients do prefer to have PCI rather than cabbage, even if cabbage will drive this same patient to a long follow-up and long-term outcomes. So I think it's not against surgery. It would probably, I think this is the main point when for the papers I have seen, that it's better to perform like this than PCI alone. Because especially in Europe, in France, I can speak about that, most of patients rather have PCI, even if cabbage is better. So I don't have any answers, but we need to move on, especially with our societal condition.
Right.
Other questions from the panel? Louis or Professor Uchimuro?
I have a question. As Q&A corner, Dr. Takanashi presented the question. In Japan, most Japanese patients have dominant RCA, and in Japanese patients, there are many RCA right coronary arterial region in three vessel disease. In mixed approach, revascularization to RCA is enabled. What strategy do you have if patients have right coronary artery region in three vessel disease?
Actually, the hybrid revascularization that we perform in our center, this is for very, very few patients a year. So with patients that are totally suitable for cabbage, we will perform cabbage actually. But for patients that are in very high risk for cabbage, that not anatomically suitable for PCI, we will perform an hybrid revascularization. But I think this is for less than 10% of our cabbage. So if the RC, in case of dominant right coronary artery, we will perform the cabbage, certainly.
Okay, thank you.
Thank you.
So the last question from the audience, how long to wait between both procedure in two steps, HCR, maximum and minimum times, Dr. Tomasi?
Thanks a lot for that question. So first of all, I am quite sorry because there is a lack of data to answer properly. So we can have the one-step ID for in the case of two-staged. The idea is to perform that in the same hospitalization. So the patient will recover from the cabbage during the first few days. And then when the hemostatic status is okay, we will perform the PCI and using the dual antiplatelet therapy. So it will be performed during the same hospitalization, or the other possibilities to perform the PCI the same day in the morning and then cabbage in the afternoon, and we use the DAPT the day after. This is the two main reasons.
Sorry?
Are you free?
Okay. Thank you very much. We can move now in the next presentation. It's an honor for me to introduce you, and I don't know if I can introduce you, Professor Mishra from India and New Delhi. I have the privilege to visit him in New Delhi and to visit his marvelous institution. It's not, you know, I'm really sincere when I told you like that, because it was very exciting to see how the modern surgery is practicing in India, and especially in New Delhi. So thanks again, Dr. Mishra, to invite me. And I would like to thank you too, because you accept to come in Brittany, to come in Rennes, and to the French president meeting. And it was really a nice time to share with you. So Dr. Mishra, after two quiz, you can go ahead. Thanks a lot. As you want. Please, Professor Mishra, it's up to you. Thanks
Good evening. Good evening, friends. At the outset, let me thank PETERS Academy for giving me this opportunity to be with you in this evening. And special thanks to Professor Verhoye for a nice introduction. Thank you. I again dreaming that you should come to New Delhi, to my institution, and do some your magic, some good surgery. We have grown since you visited. Recently, we just concluded our ISCTS annual meeting on virtual because of the fact is Corona. But eventually, I think maybe the year end, we may have some maybe hybrid or in person. Let's see how the pandemic falls. Let me share my slides. They are here. And can you see my slides? Can you see my slides, Alexander?
Yes, yes.
Okay.
Yes.
Very nice.
Yes. So I was being given a topic to talk about the minimally invasive coronary artery surgery, and in special reference to the use of Cygnet flexible clamp for performing proximal anastomosis. Friends, let's see. On your left side, you see this is a kind of incision worldwide. Most of the centers are making to carry out coronary artery bypass surgery, total revascularization, whether on pump or off pump, total arterial or arterial vein radial. On the right side, now this is a surgery which I'm going to talk about, where you can do the total myocardial revascularization, sometimes Lima and Reema, sometimes using direct vision, mammary artery harvesting, sometimes as Dr. Labrousse shows, use of endoscope and robotic technology, and use different tools and hardware to stabilize the target area and do coronary artery bypass surgery. Now, friends, you can ask what are the benefits of this minimally invasive coronary artery bypass surgery. Now, with this newer advances which are taking place and technology is available, we can perform complete revascularization with a small thoracotomy, or what you call a minimally invasive coronary artery bypass surgery. Now, minimally invasive CABG generally takes less time now as compared to the conventional, because you need not to close the sternum, you just quickly finish your surgery. So these are the advantages which we are now experiencing. Now this also maintains the same principle of normal off-pump coronary artery bypass surgery. Now, a small 5 to 7 centimeter posterolateral thoracotomy provides improve outcome of the patients, and also the referral physician also feels good when they refer and patient goes back to them after this kind of surgery. There is a certain intubation time, ICU stays less, quicker return to the normal activities, and less restriction post-surgery. This increases the referral base to, and of course, this makes a marketing tool to our, institutions. Now, is every patient is a candidate for minimally invasive coronary artery bypass surgery? To my mind, no. There are patient selection criteria. There is some inclusion criteria, and those are based on the coronary anatomy in the coronary angiogram, and also the prevalence of comorbidities which are not appropriate to subject the patient midline sternotomy and do on-pump or beating heart surgery. Now let's see what coronary which is appropriate to do minimally invasive surgery. If the patient has a left main coronary artery disease with normal right coronary artery, it means that the left main is supported by the normal right coronary artery. This is a candidate. But if an individual has got a tight left main and also tight right, then that is not appropriate candidate for beating heart. One can do on pump if that is the situation, if the patient is very persistent to want a minimal access. Now, the triple vessel disease with medium to large posterolateral, that is PDA, that is also an appropriate target. Now, the complex proximal left-sided lesion with or without large branch involvement, ostial LLD, ostial circumflex, those are the ones which are not giving very long-term stent results. So those are the candidates where we can do a minimal invasive surgery. Now, if there is a previously unsuccessful stenting, we are getting a lot of patients where they could not able to cross, or there is a CTO or 100% LED. So those are not, the patient may not succeed in that one. Now, some of the comorbid conditions, if patient has like a long-term steroid therapy, this is appropriate to do through this approach. Advanced age, need for further major operative procedures. Some of the patients, they may go subsequently to knee surgery. Now, those are the patients which may get benefit out of this minimal access surgery. Now, severe deconditioning and patient with arthritis or arthropathic problem, and of course, diabetics, young patient, if they require 2 mammary arteries, if we do through sternotomy, the wound healing may be a problem. Now, so I just mentioned every patient is not a candidate. What are the contraindication? Now, the patient who are in emergency situation or patient with hemodynamic instability, those are the contraindications, absolute contraindication to go for minimal access coronary artery surgery because they may require a pump assist anytime. Now, the potential contraindication are morbid obesity, particularly when you are starting the program. If you are not too experienced on that, patient with a posterolateral branch disease, if the ejection fraction is less than 20, because it's very difficult to lift the heart and bring into the operating site. Patient with peripheral vascular disease, because you may require some time urgent CPB, but if the vessels are diseased, then it's difficult. Patient with a dilated cardiomyopathy, again, big heart, and of course, if there is a skeletal deformity in form of PETERS, those are not the good candidates. Now, let's see what is the incision mean. So normally we make an incision in the 4th or 5th intercostal space, 1/3 medial and 2/3 lateral to the neck. So this is a usually, and the which space, 4th or 5th, depend on which kind of vessels we are doing. We are doing only the left-sided, then it's fine to go to the 4th. If you are also going to the PDA, it's better to go. And also the better idea we see when we see the X-ray chest and see the location of the apex of the heart. Now, these are some of the hardware which one require. We require a small retractor. We also require, minimal invasive use starfish, and of course, octopus nubo. These are the ones which are now available. We also require mammary lift retractor, which is being shown here. Now, this mammary lift gives us a very nice, tunnel where we can dissect the mammary on direct vision For that, we have to sit down and slowly, I will show you how one can go for dissection. Then for a partial occlusion of the clamp, we can use a Cygnet clamp. This is a flexible clamp, and the handle is not there, so you can have a bigger space to do the proximal anastomosis, which I will show you subsequently how I am carrying out that. And this is here you can see that the Cygnet clamp is in place. Now, the small shaft is way away from your incision, and you can very nicely perform the proximal anastomosis. So, friend, let's move on to see how we carry out the mammary harvesting in our. This is a patient where I have to do 3 to 4 bypasses. And this is the way, this is a fifth intercostal space incision, 1/3 medial and 2/3 lateral to the nipple. Now, this is a Lima lift retractor from Medtronics, which is known as a thoratrack. And after deploying that, one has to slowly start dissecting the mammary artery. I, in my practice, usually do skeletonized mammary arteries, even for a Lima. If the bilateral, that's always a rule. Slowly, one has to start dissecting, and you can see that the vision is same like you are doing with stenotomy, because you are dissecting the mammary from not from very close, like we are doing for mid-cap, but we are on the lateral side. So slowly, we dissect the mammary artery, and now in this situation, what we are doing is that we can go all the way, from origin to the bifurcation. And after doing that, one has to, give a heparin, divide the mammary artery, open the pericardium, and then try to go for target vessel identification. Now, one can also, Dr. Labrousse has shown that one can utilize a robotic technology. I also use a robotic technology to take down the mammary artery, whether it's a single mammary or double mammary, and and this gives a very comfortable post-op period to the patient, because there is no much of retraction to the skeletal. Hence, the pain is comparatively less. Here also, with the mammary, the robotic mammary also, I prefer to take down the skeletonized mammary, which one can see here. Slowly, anyway, Dr. Labrousse has already shown. I'm not going to take much of time, but my take is that these are the tools which are available today to give a better, the comfort to the patient in post-op phase, avoid the much of the pain, which usually they get after thoracotomy incision. So let's move on, and I'll show you how after this one can deploy. I've already mentioned the, the partial clamp, which is Cygnet clamp, and do the proximal anastomosis. In our practice, we take down the endoscopic vein or radial, and with this clamp, we can also do the proximal to the radial. Now, this is the clamp where we have to change each time. This felt has to be changed, because if you will not change, the grip is not good. And particularly in a minimal invasive situation, if your clamp is dislodged, you are heading. That's a problem. So one caution is that each time when you are using, you must change those felt, and you will get a better stable, the clamping as we get with a conventional clamp. And after doing that, one has to make a step, punch it, and do 1, 2, or 3 proximal anastomosis, depending on the requirement of that particular patient. Usually before that, we always mark the venous so that there may not be kinking. We have also done some of the radial arteries. I will show also that I have also utilized this to the descending thoracic aorta when we were doing a posterior mid-cap. I will take up that subsequently. Now let's see. Let's see how another clamp, conventional clamp, when we apply, how little awkward one is when using a conventional partial clamp than a Cygnet clamp. This particular case, we used this was early on when we didn't have a Cygnet clamp. We used to use a the partial conventional the partial clamp, and we used to have some issues with that. let's see that, move on. And this is a clamp. You see that we are applying this clamp, and sometimes the RVOT comes in the clamp. That is very dangerous situation. And then the both arms of the clamp is in front of you when you are doing the proximal anastomosis. So this is a comparison. You know, you have seen that how a Cygnet clamp gives you a very, very clear area. There is nothing. It's a you know, the soft clamp and the arm is going away from your vision. But here, this is a conventional clamp where you are doing the surgery. The clamping is good, but only issue is that you know, the clamp comes in front of you. So let me move on, and let's show you how one can do the double mammaries with this approach. Here, this is a dissection of the Lima and Reema through the thoracotomy, and then what I'm going to do is to make a Lima and Reema and do a 3 to 4 distal bypasses with the total arterial kind of thing based on the 2 mammary arteries. So let me fast forward and show you how we go. So this is, we have freed the Reema, and then this Reema is going to be anastomosed to the Lima like this. So this is a platform we created from putting a piece of a glove in the octopus nuvo, which is a platform where we keep the Lima, and then we are performing this Lima, Reema, Y, RT, whatever you can say, and after that we can complete the distal anastomosis, and I'll show you what gadgets we are using for distal anastomosis. So this is a completed Lima, Reema, Y. Then we are going to put in octopus nuvo. This is measuring the length of the Lima to the LAD. You see that this is a classic Indian patients has got a diffuse coronary artery disease, like it being shown here. Now this is octopus nuvo, which is being stabilize the LAD area, and slowly we are dissecting and going to perform Lima to LAD, and then subsequently obtuse marginal and PDA with the Reema, which was anastomosed to the Lima. So the anastomosis is here is a little tricky because we are doing the anastomosis from the left side, not conventionally from the right side. As Dr. Labrousse has shown that we have to have a proximal control, make a arteriotomy, and then put in a stent so that your flow resume distal to the LAD and like other vessels also. And then you complete. So you are not in hurry. The anastomosis is really important, and one must give enough time to perform enough, because you know the issue is the lot of criticism used to be for these minimal invasive coronary artery surgery that we surgeons are using only Lima and the rest of venous graft. So now we have opportunity, and now technique is there where we can do the total arterial revascularization, like in this particular case, and that is always one. In my practice, always I measure the flow, and this is transonic flow meter, and which we and this I am doing since last 15-20 years. Since then, technology is available, and moving on to now. This is a Starfish which is being deployed, and then we are rotating and getting the target area in front of that. Now, the beauty of minimal invasive coronary surgery is that we are not going to the target area, but we are bringing the target area in the incision in front of us. So one has to be very careful. If the heart is very hypertrophied, patient may get a hemodynamic instability. So one has to be very, very careful when choosing the patient. So now this is another example. This patient had a coronary artery surgery 15 years back. Now he came with angina. We did angiogram. He had a patent Lima to LAD. Now he required 100% RCA blood, and he required a graft to the PDA, and cardiologist could not able to perform the angioplasty because this was a 100% blocked, the right system. So what I proposed is, in this particular case, I did a posterior mid-cap. See that this is adhesions from the previous surgery. Slowly we dissect out that, and if there is an adhesion, there is not too much of bounce in the heart. So stabilization becomes very, very easy. And after moving on, then I have to expose the descending aorta. Most important thing that we must screen the aorta beforehand with the CT. In this particular case, I utilize a radial artery because the kinking is not much. And with one radial, we can do a couple of distal anastomosis, snake or jump graft if need arise to the obtuse marginal, PDA, or posterolateral branch, whatever. With one radial, we can do. So the kinking is not there. You don't need too long a length because we are doing the proximal into the descending aorta. But only thing is that these patients, older patients, they do have a the lot of calcification in the aorta. Again, this is a use of Cygnet clamp, beautifully done. We are utilizing the Cygnet clamp into the descending aorta, which sometimes is having some atheromatous plaques. And then what I'm going to do is that I'm going to do a proximal radial artery anastomosis. And always when we do this kind of surgery, we always do the proximal first and then the distal, because then the lie is good. We have to divide the inferior pulmonary ligament, so there may not be kinking of the graft, and then perform a proximal and then eventually go to distal, which is very straightforward. So this is again a beautiful tool, Cygnet clamp, which can be applied for partial clamping to the descending aorta like this one. Now let's move on. And what is our results? I'm not going to talk about the literature. I have focused the way I do minimal invasive coronary artery surgery. These are some of our patients. Beautiful scar healed after 6 months, and beautiful this small incision. And with these 3 incisions, we could carry out triple vessel bypass surgery. And eventually, this is the way we grown. Earlier, we used to do midline sternotomy and arrested heart. Then we move on to the beating heart. Then when we got the lower partial sternotomy, where we have to do Lima to LAD and Reema to right system. But now we don't go because our cardiologists are so aggressive, they stent left and right. So, but initial days, we used to have the lower partial sternotomy, dissecting the 2 mammaries, Lima, and then doing beating heart, LAD, diagonal, and right. Now, once we got a robotic technology, which I started in 2002, we started doing a Lima and Reema dissection and then making a small cut, and on direct vision, we used to do 2 to 3 vessel bypass. And as Dr. Labrousse showed, this is a right lower hand. This is a TCAD, Lima to LAD with the help of stabilizer. So these are, friends, my experience, and I will be happy to answer any questions. Thank you. Thank you very much.
Dr. Mishra, for this nice presentation. I would like to insist that that you show me that in the real life, and it was really extraordinary. And I would like really thank you for all the tricky things to do and to perform a nice surgery in beating heart. I know that Professor Labrousse is impatient to ask you a question. So, Louis.
Yes, so Professor Mishra, congratulations. It's an amazing presentation that we have a privilege to see today. And well, I have to say that I was very, very impressed by the way you, as you explain, you bring up close to you the target vessel. So my question is regarding learning curve. How long do you think it's a normal learning curve for such a procedure, and how do you train your resident?
Right. This is a very pertinent questions. And Professor Labrousse, what is important? Remember that I visited, the Bordeaux to learn. Likewise, I traveled extensively worldwide to learn this technology since last 20 years. So initially we started with, mid catch, single vessel. Then we started multi-vessel coronary bypass surgery through sternotomy. Once we mastered that, and we were doing anyway Lima to LAD, that Manny Subramanian used to come to us and he used to teach, and same Calafuri. So from them we learned that Lima to LAD, and sometimes we utilize, I'll tell you, the robot to dissect the Reema and do the Reema to the PDA, the long dissection and to the distal. So those are the situations which started learning. And if you are already doing a Lima to LAD through thoracotomy, it means in this kind of surgery, there are two aspects. One is to nice, very nice, neat dissection of Lima or sometimes Reema. So that is a prerequisite. Like in heart port valve surgery, you must know how to cannulate the femoral vessel. That's correct. Same here, taking down the nice uninjured Lima is very important. And once you have achieved that, and you are already doing op calves, then it's not too difficult to go and carry out multivessel minimal invasive surgery. Of course, there's a learning curve because you have to stabilize the heart. I just mentioned, like if the heart is very hypertrophic, if you suddenly bring the heart in front, patient becomes unstable, because what happens that, and sometimes, you know, the right outflow tract, if you are lifting the heart, and then there is angulation, and then of course cardiac output go down. So one must learn the techniques how to slowly rotate the heart, particularly hypertrophic, and sometimes if ejection fraction is 30%, 35%. But otherwise, if normal LV patients, not a hypertrophic heart, is very easy to bring the target area in front of you and carry out. Yes, of course, for my resident, like in my practice, today I did a, the robotic AST with a new team. Earlier, when I was in a SCART Heart Institute, our team was different. Now here I have a new team. Today, I really struggled because what you need, you are doing robotics since long time. So robotic ASD, my team was new. We took a long time. And I was afraid whether I will be able to join you or not. So that's the situation. Same is with minimal invasive. So what I do, I always first give them to dissect the Lima through the thoracotomy. And then eventually, once they started doing that, then we give them Lima to LAD anastomosis, and then go to posterior and lateral valve. So there is a definite learning curve. But now the tools are available. The technology is there. Lot of now instrumentation is there. So stabilizers are there. So we are getting better and better. Thanks.
Thank you so much. Thank you so much, Dr. Mishra. I have now two small and focused questions from the audience. Is how to harvest the right MID or the right IMEA from the left.
Yeah.
And the second one is, do you have some problem with the lung exclusion after the surgery in terms of respiration and ventilation?
Yes. So first, let's start with the lung. Second question first. Now, forehand, when we take up the patient for surgery, we always do a PFT. If they are a smoker, they are older patients, we always do PFT, because when we, of course, we are dissecting even the Lima, and particularly if you are dissecting the both, whether robotically, endoscopic or direct vision, you are putting the patient on a single lung ventilation. So sometimes the patient may not tolerate. In those situations, what I do, then I give high frequency, low tidal volume ventilation, and the both lungs are ventilated, and slowly I put in a pack to the lungs, while both high frequency, low tidal volume ventilation, and I could able to do even a robotic Lima harvesting. So those are the rare situations, because we are not supposed to take those patients who cannot tolerate, and so who are a smoker, and PFT is not good, so usually we avoid. But if intraoperatively we see that a saturation is not, PO2 is not appropriate, then we ask our anesthetist to do a high frequency, a low tidal volume, both lung ventilation, and then we complete the Lima harvesting. Now about the Reema harvesting, now what you do, that we have a retractor. Phalanx has developed the retractor where they have a hook. So we have to make a nick into the subjugated area, put that hook, and then put into the retraction, and that's why we can create a nice tunnel on the right thorax, and then after dissecting the Lima, then go to dissect the Reema. Some of the people, they dissect the Reema first, and then come down and do the Reema. For robotically, Dr. Labrousse may be agreeing that when we do Reema and Lima dissection with the robot, first we do the Reema because dissected Reema comes on the way and that can injure. So first what we do, we dissect the Reema, then come down and dissect the Reema. So that way we develop the tunnel with the hook retractor, retract the subgyphoid area and then develop a tunnel and carry out. We need a long instrument. Sometimes, reaching all out there, we can change the energy source. We can use a bipolar system and carry out the dissection of the Reema and Lima. Thanks.
Thank you so much. We have now to move on to the last speaker, but not the least. I would like to introduce you Dr. Uchimuro from the marvelous department of Kawasaki. And I know that because one of my colleagues and Dr. Tomasi went to the Kawasaki hospital and see and meet that wonderful teams. So Dr. Uchimuro, excuse me, for the nice dissection of the lady. Okay, just 2 quiz before.
Yeah, thank you. I'm glad that I make a presentation in this exciting event. Then I share my slide. Can you see the slide?
Yes.
Then begin. Today I'm going to talk about open coronary endarterectomy for full metal jacket LAD disease. As you know, since the widespread adoption of PCI, implantation of multiple long overlapping stents is often performed to treat diffuse coronary artery disease. Full metal jacket of left anterior descending artery generates a programmatic coronary for cardiac surgeon. We show our surgical revascularization in patients is full metal jacket of LAD. First, we show a surgical strategy for diffusely disease LAD. We perform internal thoracic artery grafting in long-onlay fashion for diffuse region. When the region has a heart plaque or multiple stent, endarterectomy is required. Next, I show you a patient I experienced recently. A 51-year-old female with unstable angina was referred and transferred to our institute. She had 5 times PCI, 5 giant stents in LAD, and 1 giant stent in LCX. CAG revealed 3 vessel disease involving in-stent stenosis for LAD and CX. The preoperative angiography of left coronary artery showed severe in-stent stenosis of proximal and distal LAD and proximal and distal LCX. Right coronary artery had CTO region in mid-segment. And we can see multiple stents in LAD. We performed open CABG January 29th. I show you the video. Firstly, touching the LAD and evaluate and incising LAD. Dissecting between adventitia and atheromatous core, including stents. Now, inside LAD, and we can see the stent in LAD. Developing endarterectomy plane. proximally and freeing atherosclerotic core, including stent with detector, and extracting from proximal LAD atherosclerotic core with stents. Then detecting distally atherosclerotic core, we take a care not disrupt side branch intima. We dissect atherosclerotic core with stent carefully to distally. We cut the healthy intima, distal LAD, and passing 1.5 millimeter probe into distal LAD lumen. And trimming the intima at distal LAD. And we fix the intima at distal LAD with 8O polypropylene continuous suture. This is in order to keep good distal runoff and to prevent distal occlusion. Then removing debris on the endarterectomy LAD bed. And suturing adventitia to approximate proximal LAD. It is performed to prevent the proximal intimal edge protruding into the anastomotic site. Cutting back theta to the appropriate length. In this case, about 8 to 9 centimeters. Starting anastomosis at here with parachute technique. And first, suturing far side or proximal portion of anastomotic opening. In suturing, we take care to exclude endarterectomized coronary wall. And stopping suture on the way and change another stitch. And next, suturing near side of proximal anastomotic opening. We use some stitch in order to prevent pass-string effect. Then suturing far side or mid portion of anastomotic opening. Then suturing near side of mid portion of anastomotic opening. We exclude LAD bed. And distal end, suturing at 2 with parachute technique, so-called double parachute technique. It has two merits. First, we can cut ITA at appropriate length. Second, subsequent anastomotic suture get easier. suturing far side of distal portion of anastomotic opening. And lastly, suturing near side of distal portion. Endarterectomy and later only patch grafting of 8 cm was completed. Post-operative CAG revealed patent LAD, later to LAD with diagonal and septal branch patency. And SVG to RCA and SVG to OM branch and a free writer to PL branch, all patent. Postoperative course was uneventful and discharged at 70 postoperative day. We show clinical data of LAD endarterectomy. During past 70 years, 244 patients underwent LAD endarterectomy and ITA long-onlay patch grafting. 93% completed off-pump surgery. Stent removal was required in 26 patients. 30-day mortality was 0.8%. Patency of ITA to LAD was 92% in early angiogram, and immediate PCI was performed in 40%, 40 patients. 1 year after, graft patency was 97% in late angiogram. We published long-term results at 2017. At 5 years, all-over survival was 89%, freedom from MACE was 74%. Various methods of coronary endarterectomy have been described. I introduced a recent article. New Zealand cardiovascular surgeon L. Gamel in New Zealand reported on-pump arrest open endarterectomy following saphenous vein patch and ITA grafting. Graft patency in early and late angiogram and long-term survival and free from angina was similar as a result. I think that ITA graft was preferable because of good long-term patency. Now I introduce a surgical method. First, off-pump beating surgery can be performed safely under stable conditions. I think it is because that myocardium with diffusely disease LAD have tolerance to ischemia by daily preconditioning. We take care about ventricular arrhythmia after reperfusion of LAD. Off-pump is preferable because it leads bleeding, blood transfusion, and avoid aortic clamping. And second, fixing suture of healthy intima at distal end of the endarterectomy. It is mandatory to avoid distal occlusion and keep good runoff. We develop endarterectomy and cut intima at healthy area. We fix the distal end of intima with 8O polypropylene continuous suture onto the coronary bed. Third, we take anastomosing suture excluding endarterectomized coronary wall. Coronary wall post-endarterectomy is composed of only adventitia. We anastomose ITA on LAD so that most of LAD vessels will be replaced with ITA materials. It is important to avoid thrombosis of anastomosis. Finally, the conclusion. Full metal jacket endarterectomy can be accomplished in a safe, and acceptable manner with good long-term outcomes. We believe that off-pump endarterectomy with ITA grafting is the best option for full metal jacket LAD disease. Thank you for your attention.
Thank you very much for that nice presentation, Dr. Uchimuro. Takanashi Sensei, Hajime Mashite, and it's a real pleasure to have you on the screen now. And I think
nice seeing you.
And I think you can discuss with your colleagues about this endarterectomy of the LAD. I would like to ask you a question. I think this very nice presentation is very interesting about the removal stent that it's possible to do. Could you precise us which kind of stenting LAD we can try to remove the stent and try to do your techniques, please?
Thank you for your asking. For me?
Yes, and
Dr.
Uchimuro, of course. Both.
Dr. Uchimuro, what is your comment?
Dr. Takanashi, please.
Yes, I can ask you
asking, question. Yeah, okay. You're asking what kind of stent or what kind of appropriate LAD?
Yes, the length of stent is possible to extract or remove.
Yeah, thank you very much for your excellent question.
We do for 2 or 3 or only one stent.
Okay. I think it is important to find a healthy portion of the LAD in the far distal portion of the LAD. The far distal portion is important to make secure lumen to make good flow, good blood flow. That is the most important point. So you can fix the intima at the distal part of the LAD. Even if the thickness of intima is somewhat thick. So you can fix the intima at that point. It is the most important point. And second, so you can reapproximate the adventitious at the heel portion, anastomotic heel portion of the LAD. That is to prevent the occlusion of the patch anastomotic site because of the intimal core. The 2 point is an important point to make excellent result of this procedure. Can you hear?
Yeah.
Is the panelist have some question? Professor Mishra, Professor Labrousse?
Yeah, so my question is excellent technique, and we do get some of now these patients with a metal jacket, 2 or 3 stent. The cardiologists, they go on putting 1, the 2, the 3. So the question is, Dr. Takanashi, which kind of conduit you prefer? Most of the time is the Reema, radial, or waves? Which stent you prefer to do, patch plasty?
Thank you very much for your good question. So Reema is only one option, only one your selection to do this procedure. Other graft is not so good result for this procedure. Reema is a key graft. Yeah. So congratulations for your hard work to mix surgery. So have you experienced such kind of our procedure from the mix approach?
We have done some, not this much extensive endarterectomy, but we have done endarterectomy of LAD. not by choice, but suppose we land up, we open the LAD and we find that there's a extensive disease, then we have done limited. And in our extensive experience, we did publish a lot on the endarterectomy, our experience. And we also compared the vein versus Lima, and we found that the Lima is better survival than the vein graft. Another thing is that you stress to clear the branches, septal branches, diagonal branches, because most of the times when you do the endarterectomy in LAD, if you don't clear those, then we are creating a tube. So there is no distal flow. Then the chances of graft occlusion very high. This is very important that we must at least a septal 1 or 2 and some of the diagonal, if you can core out, there is a distal runoff and the graft patent for a long time. Your question to the limited incision, we have, but not extensive, not the metal capable. But if there is, now we open the artery, there is a not a good lumen, then we can do. And anyway, we know that now beating heart surgery is a better, that taking down the core or doing endarterectomy is better than a twisted heart.
Yeah, thank you very much. I have experience of Indian people in IJN in Kuala Lumpur, so adhesive diffuse disease LAD, I can see that.
Right.
That's terrible. Thank you.
Another question for Dr. Uchimuro from Dr. Tomasi.
Dr. Uchimuro, thanks a lot for your presentation. I want to ask you if you do encounter a very diffuse disease, will you go to perform a multi-vessel endarterectomy, or your main concern will still be, of course, the LAD, and the other arteries can be treated another way?
Oh, okay. Thank you for your question. If the other coronarity in LCX or RCA have plaque where that I want to graft anastomosis, I perform only long-onlay, short-onlay patch grafting, on the anastomosis site in LCX and right coronary. But there are a few patients that requiring endarterectomy. In LAD, there are several perforator side branch to get complete revascularization. The endarterectomy get good effect in LAD. However, LCX and RCA, I have few necessity to endarterectomy.
One last question, Dr. Uchimuro and Dr. Takanashi, could you perform control at the end of the anastomosis like did Dr. Mishra with the Doppler? And did you have some control with the Doppler at the end of the anastomosis? Like a Medistim, Doppler or ultrasonic control.
Transient time flow.
Yes, the transient time flow of Medtronic.
We don't use Medistim. Do you mean anastomotic figure imaging examination? Several years ago, we used ICG staining test after completing anastomosis. Now we use transitometer only, and we don't use Medistim examination of anastomotic figure.
So I make a compliment for his comment. So we use the transit time flow meter. So because in this case, in such kind of this case, after this procedure, the patient has a hyperlemic status. So because of the removes internal core, that makes a large lumen of the LAD and septal perforator. So you cannot care of the occlusion of this vessel at the acute phase.
Perfect. Thank you very much. Alexandra, I think it's now time to leave, because we just have a very pleasant and smart session about the coronary revascularization. And we know now the technique is very artistic and very precious. And I think it's a very nice field for the young surgeon to learn heart surgery. And probably anastomosis, harvesting is a very, very interesting work to train. And after to train, it's very important to have a seniorization of the revascularization, because the quality of the revascularization is life. And we know that we can do a very nice work in comparison with stenting. And the surgeon in coronary surgery all over the world have to push and to precise and to show how it's possible to do a very, very clever, to put very, very clever indication and to do a very, very nice work. So I would like to thank you all. If some of you want to precise or to tell some words, it's possible. And I hope to come again and to welcome you in the PETERS Academy for another program that probably Madame Duval give you the thematics. Thanks a lot.
Thank you, Professor Verhoye. And on the behalf of PETERS Surgical, definitely I would like to thank you as for being and accepted to be the director of this session. I also would like to thank our big speakers, our huge speakers, for the quality of their talk, for their expertise. Professor Labrousse, Dr. Tomasi, Professor Mishra, Dr. Tomoya Uchimuro, and also Dr. Takanashi, Shuichiro, who accept to participate. And for the attendees, we are in live about 140 people, and now we have more than 500 people who are going to read the replay. The replay will be registered and shared tomorrow. And what I would like to add as well is that I would like to thank all of the attendees for their attention, and also said that you're right, Professor Verhoye, we will continue to do so to help the training on anastomosis in regional, locally, and also to conduct additional course on PETERS Academy. The next PETERS Academy session will be organized end of April on the mini-invasive mitral valve surgery, but we will keep you posted. So thank you for all, and thank you to the speakers as well, and to the moderators.
Thank you.
Thank you. Bye-bye.
Bye. Thanks.
Thanks a lot. Bye.
Bye.
Thank you.
Thank you.
Bye-bye.